Good morning, everyone. We're running a little late, but we'll try and do the best we can. And somehow, over the past few days, I've been sensing this huge distance between sitting here and, the audience sitting behind. So if there's any possibility that you can come in the first few, there'll be a little interaction because we have a very small audience. The first talk, so the course is titled is Lens Extraction Primary Angle Closure Glaucoma Justified. And the first talk is by Dr. Kumar. Dr. Harsh is the former president of Glaucoma Society of India and also an esteemed glaucoma specialist. He's going to talk about the indications for lens extraction in primary angle closure glaucoma.
Thank you, Vinay and AIOC for having me here. And we'll try and run it a little faster too. So the basic thing is that indications of lens extraction in primary angle closure glaucoma. So Brown has summed it up beautifully in past, recommending cataract surgery alone to an angle closure patient with uncontrolled IOP, even in the presence of a visually significant cataract opacity, would have been controversial. Today, avoiding a trabeculectomy in these patients is an accepted practice. So how things change. So lens extraction alone should be recommended for any angle closure patient with a visually significant cataract and should be seriously considered as an alternative to filtering surgery. That we will see what we think about, but that is what he thought. So this is primary angle closure suspects. Angle closure where there could be a PAS and there could be a elevated IOP, and once you have this kind of a disc and field, you know that it is a primary angle closure glaucoma. So basic thing is, what is the cause of primary angle closure? Is it the pupillary block? And if it is the pupillary block either in the primary or secondary, then obviously we have to do an iridotomy, that's fine. Is it a platyoiris in which even after an iridotomy the angle goes up and you block the trabecular meshwork, in which case you need an iridoplasty. But ultimately, is it the lens? And actually all the time it is a combination of all these three things, and it is really difficult to differentiate which is which. So we all know that axial length is less in occludable angles, anterior chamber depth is less, lens thickness is more, and yes, compared to normalized, this is the situation. And then what came up was the lens vault, and the lens vault is the perpendicular distance between the anterior portion of the lens and the two scleral spurs line. And what was realized was that lens vault was significantly greater in both the angle closure group with thinner lens and thicker lens. But what Dr. Ramanji then stated was, and very truly, that if anterior chamber depth is deep enough, the lens vault, even when large, would be less likely to increase the risk of angle closure, and the converse is true, that if the patient's anterior chamber is shallow, the angle closure risk would be relatively increased even if LV is small. So what is important is the relative lens vault. That is lens vault oblique anterior vault, and that came out to be the much more respected stuff. And we see that relative lens vault was significantly changed as in PAC as compared to normal controls, and that is now the standard. Unfortunately, predicting which angle closure patients will benefit from lens removal, whether clear or cataractous, remains uncertain. So all these figures are very, very good, and yet you cannot really put your finger that, all right, if it is axial length is less than this, anterior chamber depth is less than this, lens is thicker than this, you go ahead and remove the lens. So there is no strict criteria for that. And what are you doing by lens extraction in angle closure? You can remove the iridolenticular block, you can deepen the chamber. But if any damage to the meshwork is there, that you are not taking care of at all. And you have to be careful because ACG blindness is 2 to 3 times as compared to OAG, and once you have done cataract only and the patient thinks, everything is done, we are not worried, everything is cured. So that is something that we have to be really worried about. Second thing is, we always think that phaco is what is going on. No, a huge part of country, SICS is the things. And how many people would even think once to sit on the temporal side and do a 6 so that the trap can be done from superior side? None. Thousands and thousands of 6 are being done, so we have to be very, very careful by saying that only go ahead and do a lens extraction. As far as the clear lens extraction, I am leaving the studies to Prateep, who will be doing the next talk. But clear lens extraction again is there. The Eagle study did a lot of disservice on that, and we have seen now so many people are so excited. 6, there is a small spoke of cataract in the periphery. Oh yes, there is a cataract. Remove the cataract. So, but that can lead to loss of accommodation. I have had people. I had a mason I had sent for peripheral iodotomy because he was a poor person. Some thesis was going on. His lens was removed and he came back crying because there was a loss of accommodation. He could not work. It was extremely difficult. So please, lens extraction in a clear lens is a very difficult situation. When would I do a lens extraction in ACG alone? IOP is controlled on tolerable medications with PI, gonioplasty, etc., detectable cataract. Extent of field, actually now for me, it really does not matter if I tell the patient clearly that, okay, I'm going to do a lens extraction. If I require to do it, I will have to do a trab later, maybe early, maybe late, but you should be aware that it may be required. And yes, if the patient is unable to stand a long surgery, unwilling to risk a snuff out, there is an advanced damage, patient is debilitated, and control is plus minus, you can do a lens extraction because absolutely there's no option, or you can add it on with DLCP or something like that because you can't undergo big surgery. But very clear for me, if IOP is not controlled, and you can try a lens extraction, but for me, I would rather go ahead and do a combined surgery in such a patient with advanced damage and uncontrolled IOP as of now. As far as the clear lens extraction is concerned, for me, there's only one place. If the chamber is very shallow, you will have to do a trab, and you're scared of doing a trab in such a shallow AC, then yes, please go ahead and remove the lens and do a combined surgery in that case. Dr. Lam very promptly said that yes, we have done a study, and any IOP greater than 55 in acute angle closure glaucoma, please go ahead and do a lens extraction. We have controlled invariably almost all patients of angle closure by medication, PI and gonioplasty, and question of doing a lens extraction in acute ACG is extremely difficult. There's no doubt. There's a talk on that as well. We'll be talking on that as well, but it is a very, very difficult task. I don't think it is that simple at all, and I would not recommend it personally. So there's a detectable cataract, there's a visual acuity drop, IOP is controlled on medication, IOP is high, but disc is not too bad. Please go ahead and do a cataract. Otherwise, you will have to think of a combined surgery. Thank you very much.
We're inviting Dr. Prateep Vyas. Dr. Prateep Vyas, who's a former Secretary of Glaucoma Society of India and has many years of experience in all types of glaucoma. And I invite him now to tell us about the studies and what they say about the efficacy of lens extraction in PACG. Prateep.
Thank you, Dr. Vinay, for this opportunity. Good morning, friends. I would be talking on what literature says about the clear lens extraction or lens extraction in angle closure glaucoma. Unfortunately, we do not have a robust literature available which can prove that the lens extraction is beneficial in angle closure disease, but still it's my responsibility to share whatsoever I have learned from the peer-reviewed articles. So this is the classification of angle closure disease, and the first is the angle closure suspect, where obviously the role of lens extraction is not there. So I will try to take out some studies which addresses the role of lens extraction in primary angle closure glaucoma, acute angle closure disease, and chronic angle closure glaucoma. I will quote one disease for each one of them. Okay, so this is the basic science behind what we think that the lens extraction might be beneficial in the angle closure disease. Once you take out the lens, then there is an increase in the AC depth, increase in AC volume, increase in angle opening distance. So there is a less crowding at the angle. So aqueous can egress out of the eye freely and the intraocular pressure goes down. There is only single landmark trial is available in the literature as of today, which also might be having lots of drawback, but I am not here to do the critical appraisal of any trial. I will just let you know what the trial says. The first is the Eagle trial, that is effectiveness in the angle closure glaucoma of lens extraction. That's the important randomized control trial. They have recruited the patients of primary angle closure and primary angle closure glaucoma, and they randomize into the lens extraction versus the YAG-PI plus medication. They have a good number of patients in the trial recruited. That was 419. PSC were 155 and PSCG were 263. They did the follow-up for almost 3 years for this, and they thought that the lens extraction will lower the intraocular pressure, quality of life of the patient will improve, and there will be a reduction in the cost of the treatment versus the laser peripheral iridotomy and topical therapy. So the outcome was that the clear lens extraction was better as compared to the YAG laser iridotomy, but there was only slight difference in IOP reduction in between the two groups, and that is approximately 1 millimeter of mercury. So the lens extraction for angle closure disease, this was the landmark trial, but before that, the first trial was from Eric Graves and his colleagues from Netherlands, and that was based on the result of the ECCE with IOL. But with the phacoemulsification, there were few good trials before the landmark study, that is the Eagle trial. Out of these, the two were from Clement Them and his group, and they compared the clear lens extraction versus the trabeculectomy with phacoemulsification and clear lens extraction versus the trabeculectomy. Let us see that what these trials says. So there is a review article in Survey of Ophthalmology in 2020, and most of the remaining talk is based on this. In this review article, they have taken out all the trials conducted for the on the role of the clear lens extraction or the lens extraction in angle closure disease. But most of the trial have a very low sample size, so the power of study was very poor, and the follow-up is very, very short. None of the trial has a more than 3 years of follow-up. So first, let us discuss about the lens extraction in primary angle closure disease. This was published way back in Journal of Glaucoma in 2006, where they have studied the role of the lens extraction in primary angle closure disease. But all the patients, they had a cataract. The number of patients recruited in this trial were 21, and the follow-up was 1 year. So in primary angle closure glaucoma, with coexisting cataract, the cataract extraction alone by phacoemulsification can significantly reduce the intraocular pressure and the requirement of the anti-glaucoma medication. That was the outcome based on 1 year follow-up. The role of lens extraction in acute angle closure, obviously it's a very difficult and pretty challenging. So in this trial, they have recruited total 37 patients, followed up for 2 years. This was from Tin Ong and his colleagues from Singapore. So the conclusion in this study was, when it is performed, within a 1 week of acute angle closure, then with the coexisting cataract, then it can reduce the intraocular pressure significantly, and the outcome is better than if you do the laser peripheral iridotomy. Another trial, the FECO versus the laser peripheral iridotomy in acute PSC. The significant greater reduction in IOP when you do the lens extraction, lower rate of IOP failure as compared to the LPI, wider opening of drainage angle, and this study is from Professor Lam et al. Published in ophthalmology. Clear lens extraction versus trabeculectomy, it's from Clement Them and his colleague, published in ophthalmology in 2013. Again, the sample size is very small. It's just they recruited 50 patients, followed up for 2 years, and the outcome was what they reported is the clear lens extraction does reduces the intraocular pressure in primary angle closure glaucoma disease, but the trabeculectomy lowers the IOP better, but trabeculectomy is associated with more complication as compared to the lens extraction in primary angle closure glaucoma. This is another study where the phacoemulsification was compared with the peripheral iridotomy in the management of chronic primary angle closure disease. So in this study, they recruited total 13 patients and they followed up for 2 years, and there was a statistical significant reduction in the intraocular pressure. The number of anti-glaucoma medication were also less in the IOL group. So the phacoemulsification with posterior chamber intraocular lens implantation results in a higher anterior chamber depth and the volume and compared to the LPI. Obviously, it is understandable that if the patient has a chronic angle closure glaucoma minded, then the lens extraction obviously would be a better choice as compared to the LPI. This study did not discuss about the trabeculectomy. So there are lots of studies, and these all studies were included in that review article. Obviously, I cannot cover all these studies. So in summary, the lens extraction in angle closure disease changes the morphology of anterior chamber, hence reduces the intraocular pressure. In all stages of angle closure disease, the lens extraction may be effective in reducing the IOP. Important factor to determine the outcome was initial IOP, anterior chamber depth, and lens vault. That is what Dr. Harsh was discussing. The prospective randomized controlled trial with long-term follow-up and adequate sample size can address this issue. Lens extraction for the management of angle closure disease should be considered and done only by those who have experience to deal such kind of surgery. Thank you very much.
Thank you, Prateep. That was wonderfully clarified. And we now have Professor Vinay Nangia. He's the head of the Suraj Eye Institute in Nagpur, one of the premier institutions in that area, and a prolific surgeon. So he'll be talking about how exactly to do the lens extraction in angle closure glaucoma.
Thank you very much. That's very helpful. Thank you. Thank you very much to everyone who organized this conference in Calcutta and the AIOS. So I'm going to take you through the surgical techniques for lens extraction in primary angle closure glaucoma. So these are the biometric parameters in PACG, I think in a series of 75 eyes. They had a mean age of about 58 years. The spherical equivalent was 0.76 diopters. The intraocular pressure was 26.7 millimeters of mercury. The axial length was 22.64. The AQD, that's the space between the endothelium and the anterior surface of the capsule, was 2.05. The lens vault was 0.93, and the lens thickness was about 4.83 millimeters. So this is what you're starting with. This is the eye that you have in front of you. So what are we dealing with? We're dealing with an eye where the angles are completely zip closed, where the AQD is less, and we have a very large lens, or at least the diameter of the lens is very, very much, and there is a significant lens vault actually. So the lens vault in this particular patient is 1.16. That's really significant. So how do you treat these patients preoperatively. Topical steroids are considered a very important mode of therapy in eyes presenting with PACG. Topical and systemic pressure-lowering agents are very important. Some patients may respond and others may not respond to efforts to lower IOP, or maybe not respond significantly to efforts. So this depends on the edema, the degree of ischemia of the iris. Some IRDs do not respond to the use of pilocarpine and others do. The clinical presentation differs significantly. One may get a patient of PACG with symptoms of angle closure, especially redness, pain, hazy cornea, and elevated intraocular pressure, or one may get a primary angle closure glaucoma patient with a rather quiescent presentation with mild or moderately elevated IOP, with even clear corneas and no significant clinical symptoms. PACG patients with significantly elevated IOP often do not respond to medications. There is then the possibility of waiting patiently while the IOP may continue to remain significantly elevated. Or there is a possibility of doing surgery even at this stage with elevated IOP, while clinically our senses would like the IOP to be controlled and the eye to be quiet. However, given such a situation, elevated IOP is not a contraindication to surgery in PACG and may be the only way forward. For us, when we have an AQD of 2.25 millimeters, we want to be very cautious, and most patients of PACG have an AQD of less than 2.25 millimeters. Doing capsulorhexis is a challenge, so when you put in the capsulorhexis forceps and you puncture just the center and the chamber doesn't collapse, then that is already an indication that things are going to be all right as you do capsulorhexis. When the chamber shallows, then the arms of the capsulorhexis forceps tend to press on the capsule and you may get a linear tear, and that is something that you should be very cautious about. That's not at all an indication that you'll be able to complete capsulorhexis safely in such a patient actually. So therefore, it is very important that we need to deepen the anterior chamber in such a patient before proceeding any further. And once, of course, you do capsulorhexis, then the fluidics of the current phacoemulsification machines are excellent, that they will allow you to do safe phacoemulsification. So normally we would give a peribulbar block. We do a side port and we put in adrenaline, we put an air bubble, we put the blue dye, the viscoelastic, and if the air bubble sits without being pushed out, you're in luck. It really is an indication that things are going to be all right. If the air bubble gets pushed out partially or moderately, or if the air bubble sits only in the pupillary area, that means it's a small air bubble, these are indications that there is a mechanism which is not allowing deepening, or which is not going to allow deepening of the anterior chamber. Non-deepening of the anterior chamber indicates that it will be difficult to complete the capsulorhexis, and therefore AC deepening is needed. The cause of an AC not deepening enough is not known, but we may consider the possibility of a congested choroid and the role of choroidal pulsations. Todd zonules may be another cause actually. So there are two ways of deepening the anterior chamber. One is by doing a limited vitrectomy. So if you have the help of a colleague, or by doing a vitreous stab. A vitreous stab for malignant glaucoma was popularized many decades ago by Morton Grant and Paul Chandler. With the advent of vitrectomy, it was not considered safe or fashionable. We consider it not fashionable, but we do consider it quite safe even in PACG eyes actually. We use a 2 ml syringe with a 20 gauge needle. We make sure that the piston moves smoothly. 3.5 millimeters behind the limbus, we pass the needle 8 to 10 millimeters into the mid-vitreous after exposing the sclera. We aspirate the smallest amount of vitreous possible, which could just be 0.1 or a little more than that. It's difficult sometimes clinically to control the exact amount of vitreous that you are going to aspirate, so you need to be extremely cautious, and one has to go by a minimalistic tendency and ask your assistant also to watch how much you are aspirating actually. This is followed by a significant anterior chamber deepening. You need to get used to operating with a deep anterior chamber, but if the anterior chamber has deepened a little bit more than what you would have liked, then we would recommend that you may inject some normal saline into the vitreous to build up the pressure and to bring the AC depth to where you would be able to operate. The chance of getting a complication with vitreous stab is extremely low, and we have never had a lens or a vitreous touch over many, many years actually. So this is a patient that I'm showing you a surgery with, where actually the chamber shallowed, and I put in a needle and you can see the vertical streak of capsulorhexis, and so then we had to go for a vitreous stab in this patient to deepen the anterior chamber, following which it was not at all difficult to do the surgery, and this is the suture that is being given to the sclerostomy that you've created using the 20 gauge needle, and then we complete the capsulorhexis, and you can see that that's not so difficult. And that was a time when I was not using the blue dye to stain the anterior capsule, but I do use that now more often. And the remaining surgery is just like any other surgery, actually. So this is, I want to show you what happens with the air bubble, actually. This is a patient that we followed up for 15 years without touching him. He's a one-eyed patient. We just kept him on drops. He did very well. This stayed all right, actually. And then we had to operate because he developed angle closure, acute, not acute, but angle closure glaucoma, actually. And you saw how the bubble was very small, and then we did a vitreous tap, and then we were able to reform the bubble, and then we knew that we'd be able to do a vitrectomy. And you know, post-operatively, at 5 months, the intraocular pressure is 16 millimeters of mercury on no medication. And this is another case, and you can see that, you know, you had a lens volt of 0.83, intraocular pressure of 32 millimeters on glaucoma medication. You had a cup disc ratio of 0.8. The angles were completely zipped closed, and the disc was completely or almost completely cupped. And you can see the ganglion cell layer, and you can see the thinning of the retinal nerve fiber layer here. And this is a patient that we did combined surgery, and you know, the pupils were had the posterior synechia, and you can see what we do for such patients. So, you know, the chamber formed. As soon as the chamber forms, you know that you're out of the woods. You're going to be able to do surgery. And we use a vitrectomy scissors to, you know, release the posterior synechia, and also to enlarge sphincterotomies and enlarge the size of the pupil. And, you know, that gives you enough space and enough ability to do cataract surgery. And so the intraocular pressure at 1 year follow-up was 15 millimeters of mercury on prostaglandins, actually. And this is another patient with classical iris atrophy and you know, posterior synechia, and we use the vitreous scissors again to cut through the you know, pupillary sphincter, do the capsulorhexis, and you know, so lens extraction is a sight-saving procedure in eyes with PACG, and despite the skills required, it's eminently possible to do safe lens extraction in PACG eyes. Clinical skills and technology today allow for surgery in eyes with primary angle closure glaucoma. And this is a pyramid that I keep on showing just to tell you how we have evolved and what are the opportunities that are available for us. Thank you all very much.
Thank you, Vinay. I think that was beautifully shown in the videos. And we now have Dr. Pandav, who's heading the glaucoma unit at PGI Chandigarh, and he'll be talking about lens extraction alone or combined surgery. What is preferable and more effective? Over to you, Pandav.
Thank you, Vinay, for including it in the program. I have no financial interest in any of the devices that I mentioned. Angle closure glaucoma, you know the pathogenesis. I think we have already briefly alluded to it. The angle closure disease, they tend to have shallow anterior chamber, and as we advance in age, the proportion of angle closure glaucoma also goes up. And what happens is that there's an increase in the lens thickness, and also there's a little change in the position of the lens also happening. That is important. And both these factors combined, they shallow the anterior chamber. And as Vinay said, these eyes, they already have a shallow anterior chamber, and combined, if you look at the combined effect of these two factors, it could lead to shallowing of about 1 millimeter, and that could be very critical in these eyes, because these eyes already have shorter axial length and shallow anterior chamber. So that could be critical in leading to angle closure glaucoma. So the lens plays an important role, and as I mentioned, these two things basically, that the lens position could be a little anterior, and the lens is also thicker. So what that results in, clinically we see that as an increased vault, and I think Vinay has already alluded to that how you know, that the vault is actually much bigger, the lens vault in these eyes than if you compare to the normal. So this leads to irido-lenticular contact and also could lead to pupillary block, and that pupillary block can actually precipitate the angle closure. So there's a reason you do laser iridotomy in these patients, and at least you abolish the angle, the pupillary block component, and that helps. So what is the effect of lens extraction in these eyes? So clinically we have seen, and also Dr. Prateep alluded and actually shown a number of studies and data on this. So there is a substantial reduction on IOP, 2 millimeters, almost 12 millimeters of mercury in these eyes. There's a deepening of the anterior chamber and also opening of the filtration angle. And there's a decrease in the iridocorneal or iridotrabecular contact. And the studies suggest that there's a highest predictive value of initial IOP and the diameter. So if the initial IOP is high and if the lens diameter is high, then those are the eyes which are going to have maximum benefit of lens extraction. That means the IOP reduction will be higher in those eyes as compared to if these two parameters are less or they are towards normal. So how does lens extraction changes our parameters, the biometrical assessment? So we know the mean IOP, as we mentioned earlier, is significantly lower after cataract extraction in angle closure disease. The angle opening distance, or AOD 500, is significantly higher in these eyes after cataract surgery. And IOP reduction correlates with the increase in the AOD 500 value. So there's a relationship there. And also the lens volume also correlates with the decrease in IOP following cataract surgery. So AOD 500 widening positively correlates with lens volume as well. So that means the removal of the lens from these eyes actually improves all the angle-related parameters and we measure them. And this is kind of a ASOCT demonstration of the same. You can see from A, as we go from A to C, there's a marked increase in the angle width in the eye after removal of the lens, and you can see the anterior chamber depth is increased, and lens vault is practically eliminated. And clinically, we see this, every time we do a cataract surgery in an eye with a shallow AC. And the next day, you see the AC is usually fine, deep, and the pressures are better controlled. So, how do we look at the lens extraction versus phacotrabeculectomy? Now, if you have an uncontrolled angle closure glaucoma, I think this study is important, and Prateep also alluded to this. So, if you do phaco alone, there will be a decrease in IOP in the postoperative period. However, there will be a certain percentage of cases, probably around 20-25%, who will need glaucoma medications even after surgery, and some of them might even need glaucoma procedure. So even though there's a reduction in IOP following cataract surgery, but that doesn't guarantee that, it's not universal. Some of these patients, they will still need surgery because they are already advanced glaucoma patients. So at phacotrabeculectomy in advanced uncontrolled PSEG, the need for anti-glaucoma medication is significantly reduced, and this is more suitable for non-affording, non-compliant patients, basically. So basically what we are saying is that if you're not able to, if the problem with the follow-up, then better to do a phacotrabeculectomy at least. They will be benefited, for some time. So this is our own data. I think we collected data on 110 eyes. This was published a couple of years ago. And we looked at all our patients where we had done cataract surgery in angle closure glaucoma patients. And we have done for all varieties like PSCS, PSC, PSCG eyes. And we looked at the IOP trends on day 1, day 7, and up to 1 year follow-up in these. Follow-up was longer, but at least the inclusion criteria were that at least 1 year follow-up should be completed. And as you can see, the majority of our patients are angle closure glaucoma patient, and about 50%. We have around 20% angle PSCS, and PSC were again around somewhere around 30%. So again, majority were PSCG patients, and some of them were actually advanced disease, and the mean follow-up were around 3.5 years. 3.5 years. And if you look at the IOP lowering in these eyes, all eyes had IOP lowering following cataract surgery, and also the number of anti-glaucoma medicines needed in the post-operative period were lower than what was needed in the pre-operative period. And as you can see, the PSCs, PSC, PSCG all had lowering IOP, and you can notice that PSCG actually had the maximum benefit in terms of IOP lowering. So PSCG, where we tend to do surgery, some of these patients were actually, we were debating whether we want to do surgery or we want to just to do cataract surgery in these patients. And some of we settled for cataract surgery alone, and that led to a substantial reduce in IOP, as well as the number of glaucoma medicines needed to control intraocular pressure. As you can see, the advanced PSCG, the advanced glaucoma patients, they were also benefited, I think, maximally in these studies. The important thing was that half our patients were of PSCG in the study were advanced, and 11 of them were on systemic drugs, and all were off systemic therapy. They were on oral estrazolamide, and all of them were off oral estrazolamide in the follow-up period. And 6 out of the 55 eyes actually required glaucoma surgery. So their pressure was not controlled with acceptable medical therapy, and they were subjected to surgery. So this figure is just about 11%. And if we had done like the traditional, if we have gone by the usual thinking, then all 50% of these patients, then 100% of these PSCG patients were actually candidates for glaucoma surgery. So, okay, so the lens extraction versus trap. Now, if you look at the another randomized controlled trial, we have the 50 eyes, I think is already alluded to. Basically, it suggests is that at 2 years follow-up, there was a significant reduction in both the groups, but the TRAV eyes required fewer drugs. So that means the eyes that underwent trabeculectomy had a lower intraocular pressure and lesser requirement for anti-glaucoma drugs. So what about the lens extraction with a combined phaco? That's what we are actually discussing. There's no good study. I looked at a number of studies, and this is a meta-analysis which compares efficacy and safety of the phaco versus phaco-trav in PSCG with coexisting cataract. And once, I think the total number of eyes they could select for this meta-analysis was 460 eyes. So this is a good number, basically. And if you look at this study, this data, the phaco-trav had a greater IOP lowering effect, slightly greater lowering effect, but not actually much difference between the phaco versus phaco-trav. Lower number of anti-glaucoma medicines were required, so there was a significant difference in this group. The phaco-trav eyes needed much lower IOP lowering drugs in the post-operative period, and also the post-operative visual acuity and fields were comparable in both the groups. So lens extraction versus phaco-trav, if you look at it, there's a less post-operative complication in the phaco-emulsification. Now this is significant, but if you look at the rate of complications, they were much higher in the phaco-trabeculectomy group. So there is a kind of a trade-off. You can get better pressures and less number of medications with phaco-trabeculectomy, but you get more complications in the surgery. So what are the risks of doing cataract surgery? So it looks like that if you do cataract surgery or do combined surgery, more or less they are same. There's a little bit of benefit as well as disadvantage. So I think Dr. Vinay has already mentioned about how to do cataract surgery in these eyes, but technically they are a bit difficult. You may need excessive manipulations. There would be synechiae, corneal endothelial issues, and posterior capsular tear is also there, plus other issues are there. So cataract surgery is has its own complications and risk in eyes which are too short. So to summarize, both cataract surgery alone or combined with TRAV are valid options for treating angle closure glaucoma. IOP reduction appears to be marginally better in combined group, but the number of AGM required in the post-operative period is much lower, significantly lower in the combined group. And the number of complications is also significantly higher in the combined group. Thank you very much.
I hope there will be some time. Thank you, Dr. Surinder. I hope there will be some time to discuss this, although we're very short actually. And now I invite Dr. Vinay Tratra. He's going to present some cases on lens extraction in PSCG. Vinay?
So, thank you very much, Dr. Vinay Nangia, for having me. And after hearing all this, makes my work much simpler. I'm going to be talking about just two cases. Actually, it's more of an acute angle closure attacks, where you had a 55-year-old gentleman who came with pain, watering, redness, nausea, headache, classical symptoms. He had no vomiting and he was asthmatic. No family history of glaucoma, and he came to the emergency. This was all in his left eye. His his uncorrected visual acuity was 6.6 and 8 in the right eye, and 6.60 and 8 in the left eye. Right eye, the pupils were normal, no RAPD. Left eye was mid-dilated, not reacting. Slit lamp examination of the right eye just showed a shallow anterior chamber, whereas the left eye, there was circumciliary congestion, there was microcystic edema, and intraocular pressure was 16 in the right eye, was 44 in the left eye. Gonioscopy of the right eye was occludable, left eye hazy view, so the gonio was not done, and he had an acute angle closure glaucoma attack in the left eye, and he was right eye needed a YAG peripheral iridotomy. So he was given oral acetazolamide, started on steroids, mannitol given, his intraocular pressures came down. He was asked to review the next day for YAG PI. Sorry. Unfortunately, he developed COVID, got admitted into a general hospital. So a tele consultation was done. He was asked to take acetazolamide and pilocarpine eye drops by twice a day, consulting with the ICU people. He presented nearly 10 days later. His intraocular pressure on these medications was okay. He was advised a YAG peripheral iridotomy. This was done by a colleague. And following that, his anti-glaucoma medications were stopped. His pressures were okay. His fundus in both eyes was normal. He presented to me nearly 10 days later, and without medications, his pressures in the right eye was 18 and in the left eye was 34. So we did discuss. We told him we'll do a OCT, we'll do a UBM, we'll do a lens star, and then we will review. So we did a UBM, and the UBM just showed some small size cysts in the right eye. Angles were open, and in the left eye it was again some cysts, and the angles were closed. They noted that the PI was patent. So this was the OCT. The left eye did have some disc swelling, and this was his lens star. So you had an axial length of, I'll stick to the left eye, of nearly 24, aqueous depth of 2.28, and a lens thickness of around 4.66. We did his gonio again, and we could see that 3 quadrants were closed, only 1 quadrant was open in the left eye. So we advised him, discussing the various options, we did advise him phacoemulsification with an intraocular lens. Preoperatively, his intraocular pressure, which started him on IOPAR, was 14 and 28. So he underwent an uneventful cataract surgery, and he developed, we gave him just IOPAR on the day of surgery and Predford 4 times tapering, megabrom. I generally dilate my patients with atropine twice, once in the night before and once in the morning. He had developed an epithelial defect, so on the 3rd postoperative day we checked his intraocular pressure, and it was 8 once the epithelial defect had healed. So 3 weeks later, when he came for his final checkup, his vision was good, 6.6 and 6 in both eyes, and intraocular pressure was 15 and 21 millimeters of mercury, and there were just a few scattered PAS. So we told him, yeah, maybe reduce your steroids faster, and let me see you again in 3 weeks. His pressures were even lower, 18, and a month later they were 14. So we asked him to review again after 3 months, and his vision maintained. His intraocular pressure was 13 and 12 in the right and left eye respectively. His fundus remained, the discs remained healthy. So if you were to look at the course of his intraocular pressure through the different stages, it was like this. So this is our EMR screenshot. So you can see he had high pressures which slowly started tapering down and maintained along with the left eye. So I'll show a second case. This patient was diagnosed as an acute angle closure attack elsewhere. We started on IOPAR, and along with that dorzolamide and timolol. You don't need to actually combine topical and oral carbonic anhydrase inhibitors. She was a hyperope. She was around 67 years old. Her rest of the examination was okay, but she had CCC, circumciliary congestion in the right eye. The anterior chamber was shallow, and she had maybe early cataract. Intraocular pressure on these medications was 10 and 12. There was no relative efferent pupillary defect. And the gonioscopy, you can see this is the nasal angle. This was with a 3 mirror, and you can see that it is closed. The rest of it was open on compression. These are her disc photos. There was a optic nerve head swelling, but more or less healthy. This was her OCT. The left eye did have an epiretinal membrane. So this was her lens star calculation. So in the right eye, her axial length was 22.76, aqueous depth of 1.62, and a lens thickness of 4.85. So I'll just run through this. We did a cataract surgery in her. The surgery was uneventful. And so once you put the lens, you can see there is some amount of phacodonesis. So we did an intraoperative gonioscopy in her just to see what happens, and you can see that the nasal angle has opened up. There is a little bit of pigmentation, but we could easily see that the angle had opened up. So this is the pre-op and the intra-op picture. She underwent cataract surgery subsequently in the other eye, and her pressures were maintained post-operatively, and these are her pictures post-operatively. About her OCT, the disc swelling had come down in the right eye. Thank you.
Thank you very much, Vinay. And they were all excellent cases of how one would manage these patients. And may I call upon Dr. Surinder Pandey once again to give a viewpoint on lens extraction in PACT.
I think we have, gone through all the different aspects of angle closure disease and in relation to the cataract particularly. I think there's no doubt or the fact that the lens plays a role in the mechanism of angle closure glaucoma, because as I mentioned in my talk also, the lens thickness as well the position of the lens, it kind of changes with time, and with aging, I think the lens continues to grow with time, so it grows over a period of time, and also the ciliary body, zonular complex and lens, it becomes a little less efficient, the zonules become a little perhaps lax, and the lens, there's a tendency for the lens to move forward. So both these factors combined, they can compromise an already shallow AC or already narrow angle. So there's enough data in literature to suggest that there is a role of lens in angle closure disease formation and its subsequent increase in IOP. So if you look from that angle, it kind of intuitively makes sense that in these eyes, if we remove the lens, that should help. And the literature also suggests, and if you look at the biometric profile of these patients after cataract surgery, there's an improvement in the angle configuration. The only issue is that if you have advanced disease and where the angle structures are already kind of damaged over a period of time because of high pressures, and there even if you are removing the lens, opening up the angles, it's no guarantee that the typical meshwork will continue to function as we expect in normal in a normal normal case. So that means that after removal of the lens, you need to monitor these patients, and some of these patients definitely would need additional medication. Most of them would need, but some of them may even need filtering surgery. So you could avoid, to my mind, you could avoid filtering surgery in these patients in the first go, and do it again if required, because to my mind, the complication with the combined procedure are higher than if you're doing them individually. So if you're doing a cataract surgery, it's quite safe these days. In eyes with angle closure disease, maybe a little difficult, but still not too bad. But if you're combining cataract surgery and phacoemulsifications, you are actually doing a difficult surgery, and you are also adding trabeculectomy to that. And probably that's the reason that the complication rate is higher. So if you're talking in terms of combined surgery, probably angle closure disease and cataract surgery combined is not a very good idea. It's better to separate them as far as possible. And doing cataract surgery certainly does help in these eyes.
Thank you very much, Surinder.
We'll
Sir.
take it at the end.
Can we?
Just wait. We'll just finish off, and then there'll be a little, because
just
we're short of time. We
5
started
minutes,
a little
yeah.
late. Please keep your question. We're going to come back to you, actually. Please go.
So fine, we'll just, I think Pandav has beautifully summed up the whole thing. My two important points are that, again, do not forget, a whole lot of our country does SICS. So anybody who is having a angle closure glaucoma of any relevance, please, we have to spread the word that the SICS should be done in a manner so that at least the nasal area is left for trabeculectomy. That is very important. And again, if the people are not likely to come back, they will mistake that the cataract surgery has taken care of everything. And especially in advanced discs, and if they are in hands who are good at doing a combined, probably combined should be the first option. And yes, again, if the patient the medications are not suiting, he's unaffording, unlikely to follow up in angle closure glaucoma, which may come back as PL negative later, it may be better to do a combined in these situations. But for every other patient who will be a regular follow-up in your clinic, who has been following you up, you know them, they will come back. In those patients, invariably, whatever the stage of glaucoma, and even if the pressure is a little plus minus controlled, we would definitely go ahead and do only a cataract extraction.
Would you like to give a viewpoint also?
Okay, two things are very certain in glaucoma. The placebo reduces the intraocular pressure in primary open-angle glaucoma patients, and number two, the lens extraction reduces the intraocular pressure in angle closure disease, for sure. Now, what Dr. Vineet has presented the cases, both the patients, they have a good axial length, good AC depth, and the lens was not very thick. But take up the different scenario where you have an axial length of 19 millimeter and the lens thickness is 5.25 millimeter, AC is very shallow. So in these patients, the surgery is very difficult, and even you cannot predict the outcome. Many of these patients land up in aqueous misdirection post-operatively. So thanks that he gives atropine to all his patients. So that is one thing which you should keep in your mind. If the AC depth is very shallow and axial length is very less, then you must give atropine eye drops in the initial postoperative period to each and every patient. If there is a significant glaucomatous damage, then in my opinion, and what I do is that I do the trabeculectomy along with the lens extraction. So there is a further reduction in the IOP, maybe by around couple of millimeter of mercury, but that is beneficial. And majority of these patients over a period of time, they do require a medical therapy to control their IOP, because it is not likely that all the patient will achieve the target IOP like in trabeculectomy. Trabeculectomy is more predictable as compared to the simple lens extraction.
So, thank you very much, and Vinay, we're going to come back to you after this, actually. So, you know, it's always hard to have a viewpoint because there's so much controversy about it, and all the time you want to be so cautious with what you're doing to these patients. So, one of the important things is that what are the indications? We've been debating about this for a long time, and so one is that symptomatic PACG, that elevated intraocular pressure not responding to medical management, and there's no benefit of laser PI when you choose to do a laser PI. Elevated intraocular pressure even without significant optic disc damage and not responding to medical and laser management. Then you have PACG with significant glaucomatous damage and elevated intraocular pressure with medications. And you have PACG with glaucomatous damage on multiple medications but non-compliant or non-tolerant to medication. So there are various ways in which these patients present to you, and so in extreme long-standing cases with significantly elevated intraocular pressure, we sometimes also consider an RD glaucoma implant along with lens extraction, because we've had this experience that although we've done a significant number of combined surgeries, somehow it's a great challenge to get the glaucoma surgery to actually be effective and work long-term. Glaucoma surgery, as Dr. Surinder pointed out, can always be done as a second option if pressure reduction is not considered significant following lens extraction. So not doing glaucoma surgery with lens extraction in such patients may not be considered to be wrong, actually. Lens extraction with minimal medication to control intraocular pressure post-operatively is considered very acceptable. That's what all the cases shown here and studies shown here have also shown, actually. Significantly elevated intraocular pressure for several days and weeks will result in optic disc damage over several months, even after control of intraocular pressure. Therefore, there is somewhat, it's not an emergency, but there's somewhat of an urgency in managing the PACG and in reducing the intraocular pressure in whichever way you choose to take. An advantage, and perhaps the big advantage, is that the optic disc in PACG undergoes damage at high pressures, but not at intraocular pressure within the normal range. So if you had a POAG patient with a pressure of 20, 21, you'd be thinking that that's too high for this patient, but that's not the case with PACG, because these optic discs are only sensitive to very high levels of intraocular pressure. So this is a lady who was a teacher, and it's almost 15 years now. She came in the left eye with intraocular pressure of 45 millimeters of mercury. Her angles were closed. She had 80% cupping with rim pallor, and she underwent cataract surgery. She's still doing quite well with beta blocker and an intraocular pressure of 15 millimeters of mercury. And this is another patient that we had in the last year. And in the right eye, she had typical signs of angle closure with elevated intraocular pressure. And we tried a lot to see whether we could reduce the intraocular pressure, but it didn't work out very well. And ultimately, we had to go for cataract surgery in this patient. And this was the 6-month effect, actually, that you can see the disc on the left-hand side, the right eye, disc, the disc still looked quite healthy when she came. And then this is the disc at 6 months of follow-up, because she had 15 days of elevated intraocular pressure, before and after coming to us. The time that it took, a week that it took for us to decide that the pressures were not getting under control, we had to do something. So that's the impact. If you have pressures of 50 and 60 millimeters of mercury for a week or more, then you should anticipate that there will be continuing optic disc damage that will manifest 6 months or more later, even though you have reduced the intraocular pressure by doing whatever surgery you choose to do, actually. And you can also see the significant loss in ganglion cells over this period of time. So just, a broad guidelines. So if you have 360-degree sunnical closure, but also remember that, as I think Dr. Surinder showed, that sometimes the sunnical closure on the anterior segment OCT and gonioscopy, but once you do cataract surgery, a part of the angle, actually the iris falls back and the angle appears to open. There is glaucomatous optic disc damage. You'd like ideally reasonably well controlled intraocular pressure, but that's not always possible. And if you have chronic angle closure glaucoma with generally quiet eyes, I think that's the eyes being very kind to the surgeon. You should be a reasonably experienced surgeon. And as we discussed, it may or may not be combined with trabeculectomy, depending on the severity and duration of the presentation. And please do microincisional cataract surgery, use a foldable intraocular lens, and lastly, you are the person who has to take a decision. And as I always say, when in doubt, if you think that you can do something safely for the patient, then it's wonderful when you create the evidence yourself in your own clinic or in your own practice. Thank you very much. And may I ask Vinay also to please give a viewpoint?
Yes, I think you all covered all the points. These patients also a good idea to dilate with atropine and also give mannitol preoperatively. The mannitol just helps dehydrate the vitreous, not so much for the intraocular pressure reduction as much as it dehydrates the vitreous and gives you that little more space where you can work.
You had a question.
Sir, if there is synechia, then while doing cataract surgery, can you give a air tamponade into the anterior chamber to break the synechia? Does it affect air in the anterior chamber? Does it affect the release of the synechia? PAS, peripheral anterior synechia.
So, like I showed in mine, I didn't need to do anything. That's why I went to check. Now that we have intraoperative gonioscopy, so I went in to check and I hadn't done anything, but the angle had opened. So now that we have intraoperative, you can see if it's not there, you could probably put viscoelastic or just a iris repositor and just tap it down. But most of the time it would open just with your raised pressure, which happens when you inject saline or viscoelastic into the eye.
So second question, sir, without doing laser PI, YAG PI, directly can you take the case for cataract surgery? Because
yes, I didn't do a PI in the second case because the patient was willing to go ahead with a cataract surgery. So I didn't do a YAG PI because you're removing the cause.
then how do you dilate, sir? What time do you dilate?
The angle closure doesn't occur while dilating, it occurs while returning back, because while it's returning it's slower and your iris lenticular contact time is more. So it doesn't matter.
Thank you.
Yes.
I would just like to share one of my patients. This gentleman had a bypass surgery about 3 months back. So he's on all the anti-platelet drugs. So, and he has angle closure glaucoma and very thick iris. I tried doing very thick iris. I tried doing YAG capsulotomy, YAG iridotomy, and it is not opening up. I failed in both the eyes. So now I think he needs either a cataract extraction, and medically, with medical drops, he's under control. The pressures are under control. And now I'm planning to do a trabeculectomy or combined plus minus phaco surgery for him. So now, since he's on antiplatelet drugs, I can't take up the case at least 6 months down the line. So for the time being, I'm just following him up with the medical treatment. So what is your advice on this?
Yes, so like we were discussing, I think it would be safer to go ahead with just a cataract first, and then if it doesn't reduce your pressures enough on a second sitting,
Yeah.
You could.
But only problem is that he's on heavy anti-platelet drugs.
Cataract surgery we don't stop.
Okay.
In trabeculectomy we may still stop because of the bleeding, but
Sure.
cataract surgery we don't stop. So it actually makes it easier for you to just do a cataract surgery first. It would increase the space.
And sometimes when they are on antiplatelets and PI is also difficult, you can go ahead and do a gonioplasty. It works beautifully. I had shown in that also. You can bring down very high pressures very quickly within an hour. It will be normal.
Thank you so much.
So thank you very much. We're just in time, and so we look forward to meeting you next time, and I hope that this course has helped some of you at least in managing your patients better. Thank you all very much.